Hello, everybody online and to everybody here in the room, and thank you for joining us today. So we're in for a fabulous talk today from our visiting professor, Dr. Erica Liebermann. So she's from the University of Rhode Island. She is a nurse practitioner with interest in cervical cancer, clinical health and implementation science. And she's going to be talking to us today about her work to date. And we've had the pleasure of meeting with Jo through the American Academy of Nursing when we were both inducted last year. So it was fantastic to have you here, and welcome to Dublin at Trinity College.
Thank you.
I'll let you take it away.
Thank you, everyone. So yes, I'm Erica Liebermann from the University of Rhode Island College of Nursing. I'm an assistant professor there, and I'll jump right in and describe my journey as we go along so you can get to know that. I'll be talking today about gender-responsive systems for cervical cancer prevention. And I thought I'd start by just talking a little bit about my journey as a clinician, as a nurse, and also a health services researcher. And then talk about my work with the Lancet Commission on Women, Power, and Cancer, and what I'm seeing emerging more and more about gender-responsive care in general. And then talk about the landscape of HPV-based cervical cancer screening, the European models, and the status in the US. And then wrap up just talking a little bit about some of the research I'm doing in the US to help implement HPV self-collection as an option in Rhode Island. So I didn't start as a nurse. My original degree is in sociology and languages. And you'll see that that very much kind of informs my work in thinking about social drivers of health, culture, organizational, system level factors that impact health. And after I then later went into nursing and went on to get my master's as an advanced practice nurse, and have been practicing as an adult and women's health nurse practitioner for almost 25 years. I also did some work as a clinical consultant for a small non-governmental organization called Grounds for Health, doing cervical cancer screening and treatment in several countries in Latin America and Africa. And so I trained nurses, midwives, physicians in particular techniques. And it's from that work that I decided to pursue a PhD. So I felt like I had bigger questions, wanting impact in a different way. But all of this practice work, both in the US and globally, also informs my research. And as a health services researcher and implementation scientist, again, I go back to my roots a lot in terms of thinking about the kind of multi-level factors that impact health, with a particular focus on barriers to accessing healthcare and preventive care in particular. So I started out after my original degree at a sexual and reproductive health clinic called Planned Parenthood in Boston. And this was, I thought for sure I would do advocacy, policy work, but I kind of steered towards and surprised myself to be interested in the medical side of things. So worked as a clinic assistant, then went back to school, became a nurse, and later a nurse practitioner. But I consider this really formative in terms of how I started out in healthcare, because it's sort of on the margins. I don't know how it is in Ireland, but certainly in the US, abortion care is very marginalized. And at the time I was working there in the 90s, quite a setting of fear and violence. And so it was a time of big growth for me personally, and in terms of developing clinical skills, but also advocacy skills. And this being in a place that's very mission driven and a place that sees the gaps in care and tries to figure out how to fill them, whether it's in abortion care or gender affirming care for transgender patients. That sense of, we see what needs to happen. And I feel like that definitely impacted who I am as a clinical person, as a leader, as a researcher. And then I went from there to a more expanded practice in gynecology. I was working with nurses, physicians, midwives. The midwives and physicians were doing more of the prenatal care. The physicians were doing surgeries, and the nurse practitioners in the practice developed some subspecialty expertise in kind of office-based GYN. And that's where I really grew into this cervical cancer prevention expert, doing colposcopy and really focused on guideline concordant care and being kind of the resident expert to help transition care, guideline concordant care. That's also a time I began my global work And then I decided to pursue a PhD and have continued working just part-time as a nurse practitioner. Because I'm not doing complex GYN care, it's more routine care. So I have a continuity practice where patients come to see me for their routine care. And that has shifted my practice a little bit more to sort of what are the needs of women across the lifespan that may or may not be related to our focus on breast and cervical cancer prevention, but sort of broader questions about what's important to women. It also, of course, as a health services researcher, my lens is open to more population health sciences and thinking about who doesn't reach our doors in clinical settings. So that's really who I am. And all throughout, there will be sort of emerging questions, all of which have a central theme of how can we do this better? How can we deliver better care? So as a clinic assistant, as one of only 2 Spanish speakers in a large clinic, when I first was doing that, I was pulled in a gazillion directions to interpret for patients on the phone once they were in clinic, help translate forms. And at some point I just said, enough, we're not delivering high quality care. And so advocated for hiring bicultural, bilingual staff, having forms translated, and making sure that the care we're delivering is good quality. And then later transitioning to other practice, focus more on evidence-based practice and what are some of the things that get in the way of using guideline concordant care in clinical practice. In my global work with Grounds for Health, as I said, that's cervical cancer prevention in coffee growing regions in Latin America and Africa. So I was doing trainings for nurses, physicians, and midwives, initially in visual inspection with acetic acid or VIA and cryotherapy. And then as I've worked more as a clinical consultant and now board member, helping transition to HPV-based testing and thermal ablation as that technology. And those questions in global health really drove sort of a fire in me about health equity, the sense of like where a woman lives should not determine if she lives. And how can we ensure that we're delivering high quality women-centered care across whatever contexts we're in, regardless of resources, and how we can we ensure equitable access to care and to screening, particularly for a completely preventable disease. So as I said, my questions started building, and I wanted to go in a research direction. So I did my PhD at New York University and had the pleasure of studying with some folks who were really driving the science forward in terms of implementation science. And again, it made great sense to me, where it was all about context. Who are the people involved? What are the organizations? What's the culture? What are the systems? What's moving and shaking to sort of drive practice? And then in global oncology, there's emerging consolidation of evidence, particularly in HPV and cervical cancer as technologies and science evolve. Really focusing in on optimizing the testing we're doing and reaching people at appropriate ages and screening intervals. And then the Global Breast Cancer Initiative, also from the World Health Organization, to focus on earlier diagnosis and strategies, resource-appropriate strategies to really ensure that people are getting access to screening and getting more swiftly connected to care to try to impact mortality, where in many countries in the world, there's much later presentation to care and lower survival. So in my dissertation work, I did a study in the Dominican Republic, working interviewing and surveying physicians on their cervical cancer screening practices, and was also interested in knowing what they knew and thought about evidence-based guidelines for cervical cancer screening, which was HPV testing for women over 30 every 5 years. And what we found is that the providers were fully in favor of HPV testing. They had been doing it in their private sector practices as more of a co-testing model, as sort of mirroring what's done in the US, but HPV testing wasn't yet available in the public health system, so it had limited applications in that time in 2018-19. But the biggest concern was the age and the frequency of screening. So Dominican providers were at that time, and probably still are, in the practice of screening at least yearly, in some places every 6 months, and starting right at sexual onset. And they were really concerned about delaying starting screening until age 30, even age 25 was considered too late, based on this experience having seen cancer in younger women. And in places like the Dominican Republic, there's a sort of paucity of local country level research. So it's hard to have providers be convinced of global evidence that feels like maybe it doesn't apply to them. So that was very interesting. And then later I did a study in India, in Uttar Pradesh state. I worked in partnership with JPIGO, which is a large women's health organization. And they had introduced a breast health initiative in 2 states in India to provide access to clinical breast exam as a screening. So mammography is not widely available in most low and middle income country settings. In India, it's not the standard of care in public systems. So the clinical breast exams were introduced as a screening in primary care settings. There was a lot of community mobilization with community health workers to educate women and get women to screening. But what they were finding is there was a huge drop off in terms of follow-up. So for women who had an abnormality in the first clinical breast exam, they weren't making it to the diagnostic center. So we were missing those opportunities to for definitive diagnosis and connection to care. And key barriers were around continued limited knowledge about breast cancer, fear and stigma, competing priorities and women's health not being prioritized in the family, discomfort seeing male providers. So in the primary care setting, their providers had been women, but when they went to the secondary hospital and diagnostic facility, there were only men they could see. That was a barrier. And also difficulty getting to this secondary hospital and navigating the facility itself. So those were some barriers to follow up. And we know that what's one metric in the Global Breast Cancer Initiative is that we want ideally from time of a palpable abnormality by the woman herself or by a healthcare provider to definitive diagnosis, ideally no more than 60 days. So time is important in terms of better survival, especially in the setting once a woman has a palpable one. So these levels of addressing barriers to care. And then I continued to expand my team in global oncology and my collaborations globally. And one of the gaps I saw is this sort of lack of visibility of nurses in global cancer control, particularly nurse leadership. And so led a scoping review with colleagues from Hong Kong and Kenya, faculty and students, and published the scoping review on the roles and activities of nurses, particularly in cancer prevention and early detection. And then the big sort of pivot in terms of my global collaborations and career trajectory was in my postdoctoral fellowship, where I had the opportunity to work on this Lancet Commission on Women, Power, and Cancer. And you can see this key finding that is quite remarkable, that of almost all premature deaths could be avoided. So of the 2.3 million women who die prematurely under age 70 each year, 1.5 million deaths could be averted through primary prevention and early detection strategies. An additional 800,000 deaths could be averted if all women could have access to optimal cancer care. So really compelling about what can we do differently. This would be huge impact. And so I won't go into huge detail here in terms of the framework, but we used an intersectional feminist approach to highlight and try to disrupt power asymmetries in relation to cancer. So decision-making, economics, knowledge, to try to understand. So if we think about women generally as healthy individuals accessing screening and prevention, as the people experiencing cancer and living beyond a cancer diagnosis, as people caring for family members or friends, as health workers in the community or healthcare professionals, or health researchers, right? All this kind of ecosystem. And just trying to understand where we can intervene and how we can center women's voices in terms of how we can shift these asymmetries and impact care in a different way. And we proposed gender transformative actions on the outer margins there in terms of educating health professionals, understanding gender competencies, in terms of how research and knowledge production happens, in terms of the health systems, and in terms of just general care for the people caring for women. So shifting to cervical cancer prevention is sort of a perfect test case to think about these models, because It's almost entirely preventable. It's disproportionately lethal in low resource settings. And there are lots of ways we can kind of impact and shift the narrative. So if we think about the different dimensions of the framework and the asymmetries of power, one way we can start to shift things is centering women's power and agency. So shifting from narratives of, I don't know how many here are in healthcare, but this narrative of non-compliance, non-adherence, or even late presentation, which you wouldn't think is necessarily a blame, but ultimately, the sort of putting the burden on the woman without recognizing the structural constraints that impact women's decision-making power in terms of seeking care. And ensuring informed voluntary decision-making for HPV vaccination, screening, treatment, and promoting shared decision-making. So if we think about choice of screening modality, we'll talk a little later about HPV self-collection versus traditional clinician collected screening. But recognizing women as rights holders with authority over their own bodies, and as opposed to passive recipients of services, is a shift. And then transforming how knowledge is generated, and also health literacy. So we know that women with lower overall education and lower health literacy are more vulnerable, less likely to seek care and seek timely diagnosis. So investing in gender equitable cancer data systems, even how we collect data. We're having a little bit of a slide backwards in the US, but globally, certainly we're talking more about precision gather data regarding biological sex as well as gender, the more social construction. But in this case, understanding who's getting HPV vaccination, and then at least age and other sociodemographic disaggregated data in terms of screening coverage. Also countering stigma and misinformation, building trust in the information, but countering misinformation that links cervical cancer to sexual blame, moral judgment. Delivering culturally and linguistically appropriate health information. That's a big barrier in our settings. As I described in my early experience in healthcare, just sort of the tolerance for not having enough language accessible. But also designed with women and communities, not for them. And recognizing the value of folks like community health workers, nurses, predominantly women still, as important knowledge brokers in cervical cancer prevention. So the idea that improving uptake is not just about generating awareness, but about redistributing who produces, controls, and trusts knowledge. There's also a big need to address gender-based violence and addressing gender norms in general, as well as stigma. So integrating trauma-informed approaches in cervical cancer prevention, acknowledging the high prevalence of gender-based violence that may impact people's interaction with care, especially in the cancer prevention aspect that traditionally includes pelvic exams. Also addressing stigma generally related to HPV, human papillomavirus, as a sexually transmitted infection, also HIV, sexuality, reproduction, through both provider and health professional training, as well as community engagement. And making sure that services are private, confidential, building emotional safety, and trying to avoid screening and treatment that re-traumatizes, right? So we need to make sure that people have, that we're addressing those forces. And then a big one for me is sort of redesigning, reimagining health systems and how we deliver care, that puts the burden on us in the health system than as healthcare providers rather than the consumers of care. So, for instance, expanding HPV self-collection as an option and community-based screening to reduce the dependence on having to come to the clinic for screenings, and integrating cervical cancer services in all places possible. HPV self-collection makes that more possible if primary care settings aren't set up for screening, traditional screening. Also, in lots of settings in the world, integrating with the HIV services or maternal child health services to reduce what we call opportunity costs for women. So those competing priorities in terms of childcare, lost wages, those kinds of things. And certainly ensuring that there's clear funded referral pathways and follow-up systems so women are not blamed when we're actually facing fragmented systems. And promoting access to female providers where culturally relevant. But again, the idea that the service models should be redesigned around women's lives and less around our own institutional convenience. There are also this economic asymmetries and the need to really think about financial exposure. So making sure there aren't out-of-pocket expenses. I think in the Irish context, that's not as much of an issue, although I've understood from colleagues that it is a fear that the patients have, the community members have, that they might incur a cost for screening or follow-up. And also this idea of recognizing and mitigating indirect costs and things like transportation, childcare costs. In most settings, depending on how big a country is or how spread out services are, we know that most of our diagnostic centers, cancer specialty treatment centers, are going to be in urban centers. So those in rural areas face a lot of a higher burden of this kind of transportation costs, access, navigation. And developing financial navigation and social protection mechanisms for women who do require any treatment. And then in our training of health professionals, making sure that there's some gender competencies, addressing gender bias, sexual harassment that may be faced by the health professionals themselves, and disrupting existing power hierarchies as better for the health professional workforce, but also for larger systems. And then elevating leadership roles for women, particularly nurses, midwives, community health workers within cervical cancer programs. Because we know that respectful, high quality care and prevention depends on a workforce that's trained to address these inequities. And then finally, embedding gender equity in policy and accountability. We know that power is exercised through policy, financing, measurement. So making sure that national cancer control plans or US state level control plans have explicit measures and taking more of a rights-based approach. And ensuring that advocates, survivors are meaningfully included in policy design and program delivery and evaluation. So if we can map these kind of gender responsive, gender transformative actions to cervical cancer prevention with the WHO elimination pillars, those of us in the field of cervical cancer prevention, this is very familiar, but this idea of these targets, this is an initiative that started 5 years ago to set us on a path towards to the possibility of eliminating cervical cancer as a public health problem across the world. So calling on countries to advance progress with these targets of vaccinating 90% of girls by age 15, 70% of women screened with a high performance test by age 35 and again by 45, and then 90% of those diagnosed with cervical precancer or cancer treated appropriately. So if we think about this in terms of the WHO pillars and the gender responsive, gender transformative frameworks, again, the need to, we have a lot of, I don't know how we're doing in Ireland, but in the US, certainly we're facing a lot of vaccine misinformation, vaccine hesitancy, sources of information that may counter science. So more and more we need to shift this power, counter stigma and misinformation, really partner with communities to understand what some of the barriers are. And enable autonomous decision-making. People should have agency and choice, and ensuring equitable access and addressing gender norms and industry practices that might undermine vaccine confidence. But the idea that we can go beyond just uptake of vaccine to having vaccination programs that build agency and trust. With the second pillar of screening, again, redesigning care to women's realities. So as much as where it's possible, offering the option of self-collection and community-based screening as a way to reduce stigma, time costs, exposure to re-traumatization if folks have a history, trauma-informed services, and knowledge equity in terms of improving health literacy with culturally and linguistically appropriate information. And this idea that screening that reduces power imbalances and respects bodily autonomy is key. And then with the third pillar of treatment and care, again, making sure that we reduce costs in terms of treatment and deliver respectful quality care, and that there's a safe gender competent workforce. I'll shift to focusing on that second pillar of cervical cancer screening and talk about a little bit about the global landscape in terms of transitioning to HPV-based primary screening. So the World Health Organization now recommends HPV DNA testing as a preferred screening method with self-collection as an option where HPV testing is available. And European Commission, certainly Cancer Organization, all and guidelines also support this transition. By 2025, the HPV-based screening has become the standard of care in high-income countries that have organized programs. And increasingly low and middle income countries that are pursuing cervical cancer elimination policies are trying to transition to HPV-based screening. And this is based on what we've learned over the past few decades in terms of HPV and cervical cancer. So we had dramatic decreases in cervical cancer incidence and mortality with the introduction of the pap smear in the 60s and 70s. And that's a way to detect abnormal cells on the cervix. But we've moved, as we've learned more about the HPV virus as the cause of cervical cancer, we've gone to more direct testing for the virus, for the high-risk strains of the virus. It's more direct. There's higher sensitivity for detecting precancer, so we can act earlier. And then technologies continue to evolve, and we're seeing the emergence of how can we use risk stratify, how can we use technology to help us stratify risk and personalize screening approaches, including AI-assisted screening for reading cytology and also in low-resource settings for helping triage HPV positive results. So emerging technologies there. And just a snapshot, these are some examples. This may not be totally inclusive of the countries, but some have transitioned completely in their national programs to HPV primary screening. Australia was the first, UK, Netherlands, Sweden, Denmark, Finland, Italy, Portugal, and Ireland did as well. Some are in a transition or they're partially transitioning to HPV primary screening. And then self-collection is emerging a little bit differently as secondarily. In Australia, for instance, it's now part of the national program, and other places in Europe. In the US, it's more conditional. It's endorsed by guidelines, but it hasn't been there's not widespread uptake. I'll talk about that. And then in low and middle income country settings, that is the main approach to HPV-based screening to increase access, particularly for rural women. So I understand Ireland to be an early adopter of HPV primary screening with that transition in 2020, with the recognition that it's a higher sensitivity test compared to cytology, which is the pap smear, and a high negative predictive value, meaning that we can safely extend the interval to every 5 years because the chance of developing cancer in that time is very, very low. In addition, they did some cost analyses to show not just clinical effectiveness, but it's actually more cost effective. So strengths at the country level are an organized population-based screening program with fairly high screening uptake. From what I saw online, it's about, from the latest report early this year, it's about 75%, but they're aiming for 80% coverage. But that sort of national program allows for more uniform transition of guidelines as screening approaches change. It's supported by the regional European guidelines, and there is country-level commitment to a cervical cancer elimination plan. Challenges, as I understand, there's still a portion of the population that isn't being reached with traditional screening approaches, and that the colposcopy demand was higher than anticipated by initial modeling. And if anybody's involved in the screening programs and wants to weigh in on that aspect, but that I've seen that in other countries as well, that we thought it would actually over time reduce our colposcopy rates, but that is a challenge with HPV-based screening that was not understood in the modeling. And then I think HPV self-collection is being considered and introduced in pilot projects as a targeted strategy to reach unscreened populations. In Europe as a whole, the orange are the mature organized population-based programs, and then the blue are the sort of evolving organized programs. The green are still opportunistic, less population-based. And many countries that have had a long history of organized programs have fairly high screening rates, and also pretty high HPV vaccination rates, and that shifts how we approach screening. So we will start to see different protocols for screening based on vaccinated cohorts, because one of the things is that then if there's less HPV disease, then we start to have more false positives with cytology and maybe over-treatment. And so we're likely to see later starting ages and longer intervals between screening for vaccinated cohorts. But that would take accurate data on who's been vaccinated, whether they were completely vaccinated. But that's where we'll probably see that evolving, and more quickly in places that have organized, country level data and from their screening programs, as well as high coverage rates for both vaccination and screening. In sharp contrast, we do not have an organized program in the US. It's a very fragmented health system, decentralized, opportunistic screening. So even at a state level, it's a big country, right? So even if it weren't a national level, even at the state level, they aren't organized programs. So they're very individual health system dependent, and then even almost to the provider level. So there are screening recommendations, but they're not binding, they're not enforced. So it really kind of more depends on the on professional societies and the extent to which providers are incentivized to practice evidence-based practice. In some cases, and we may see this evolve a little bit, insurance reimbursement can drive that practice change, but we haven't seen that yet. So it means that we have 3 screening options. Some providers are still doing cytology alone, and that is what's recommended for younger women starting at 21 to 29, and then it's acceptable to do cytology alone up to age 65. The preferred has been cytology and HPV co-testing for women starting at age 30, and very few providers in the US have endorsed an HPV-only primary screening approach, though it has been included in the guidelines for, I would say, since 2019. And so it's been an option, but not been widely adopted. So I'll in a moment, I'll talk about HPV self-collection. That's the sort of thought, is that HPV self-collection will be part of what helps us transition to this more effective screening modality. But it also means there's a lot of confusion among providers themselves, among consumers of healthcare, women seeking screening. They either sometimes over-screened or they have lagged a little bit in their screening. So we're definitely seeing the effect of this variety of guidelines and lack of uniformity. So we know that screening works if done, but in the US, an estimated 25 to 30% are overdue for screening. So on the left, you see that dramatic decline in cervical cancer incidence or mortality in the US between 1975 and 2019. But then you can see we've also sort of plateaued. So clearly we need some new strategies. And on the right, you see from national surveys that the rate of people who are overdue for screening, or that's the rate of on-time screening, has been falling in the last couple decades. So we're definitely not making progress towards cervical cancer elimination in the ways we need to. Hopefully HPV vaccination will help that in populations that are highly vaccinated. But the other thing that's stark, not unique to the US, but certainly notable in the US, you can see that our overall incidence rate is not where we want it to be for cervical cancer elimination, which is 4 per 100,000. And we've stayed at this rate of about 7 to 8 for many, many years. And so we haven't made progress. And even more notable is that Hispanic, Indigenous, and non-Hispanic Black women are much more likely to get cervical cancer. So definitely a question of sociodemographic disparities. So we need new strategies, obviously, to reach that, sometimes 30% of women who aren't being screened on time. And we face this cultural attachment to cytology, what I'm seeing among providers. So we face a kind of de-implementation challenge. And as I said, I do think self-collection with good introduction could challenge that a little bit. But there's a need for patient and provider education and more coordinated policies, at least at the state level, ideally nationally. So what do we know about HPV self-collection? Because I've mentioned it several times as a strategy to reach unscreened women and to help us transition to different kind of guideline concordant care. We know it performs similarly to clinician-collected samples and is superior to cytology. And we know that women and people with cervixes find it highly acceptable across many, many studies. The minor concerns are, will I do it correctly? And that's usually modifiable with some reassurance, a health professional somewhat available to explain and to reassure. There do seem to be, at least from studies in the US, some varying preferences in terms of whether people prefer to do it at home or in the office or clinic. Surprising to me, there is a good proportion of people who would prefer to do their own swab. And so HPV self-collection, for anyone who doesn't know, is a vaginal swab, a simple cotton swab inserted and rotated in the vagina for 30 seconds, and very easy to do. But it was surprising to me to learn how many people prefer to do it kind of in an office setting. So still avoiding the speculum exam, but being with a healthcare provider. We know it can increase screening uptake. We know it works that way. But there are some there's a continued need to make sure that women get follow-up when they've had an abnormal HPV test, to make sure that they're not lost to follow-up. And that's one of the big concerns, I imagine, in the Irish context. They're being cautious about, we don't want this, we want to make sure that we do this with quality and care to make sure people come in for follow-up. But where does HPV self-collection fit in this kind of gender-responsive model we started with? So we don't have to look at all this, it's a busy slide, but thinking about, the extent, if we think about access to information and education, what do women need to know, want to know about cervical cancer screening? Where are we going to include them in choices and shared decision-making about their screening options? So that, and how can we, so what role can it take in terms of reducing shame, fear, stigma around if it's a more private experience, and improve dignity and care in the experience of screening? So I think it's got a role for a lot of these things. It can improve access because it requires fewer human resources and specialized care resources to be able to do the screening. It expands options in terms of where, so, agency and choice, right, in terms of where women get screened. And I think it's an opportunity for more cancer health and cervical cancer health literacy as we bring women into the conversation. But, if we think also about sort of policies that make sure women and, patient advocacy groups and community members are engaged in some of the, how do we implement this? How do we go about it? So that's the sort of way I think about this as an opportunity in terms of gender responsive systems. If we look at the HSE approach, I noted that their cervical cancer elimination partnership. So you have the expected agencies in terms of the screening service, the Department of Health, the National Immunization Office, Cancer Control Program, but you also have the patient advocates, foundations. So, we could look at that as sort of an approach that maybe has the potential to be more gender responsive to the extent that stakeholder input is factored into how something like HPV self-collection is offered. In the US, I'm seeing, so the FDA, which is the Food and Drug Administration, the regulatory agency that approves new tests, approved HPV self-collection for use in clinic settings, so in the office. In May 2024, we're going on 2 years, but there's very little adoption in clinical practice yet. And on the horizon is approval for home-based testing too, which may shift things even more. That's coming soon. But the conversation I hear in practices and in research is this sort of conditional, by exception, only for people who really don't want to have a speculum exam. And that's a narrative I think we can shift, sort of why cannot people not be fully informed of the pros and cons of each option, and we take more of a shared decision-making approach. But that would take letting women into the conversation, and people with cervixes into the conversation in a different way. So I will be curious to see if as home-based collection is an option, and I imagine that means companies will do much more direct marketing to consumers, how that conversation may shift. But that's what I've observed in sort of the circles I'm in, both in practice and in research. It's sort of the yes, but, all these worries about the disadvantages, which there are some. But so that I hear a lot of concern about we need to make sure that people understand they have to come back to the clinic, and that it does involve a speculum exam if they have an abnormal test. But I believe women can make informed choices, and the proportion of women who have to come back is very small compared to the number of women we could screen. So if we screened 100 women, people with cervixes, only 10 would need follow-up in an exam, right? So that's pretty good statistics, maybe 20. But so anyway, and I do hear this language, clinician collected being preferred. So anyway, we may shift the dialogue as I think the public becomes more aware. I think that's what will shift the conversation. So just to wrap up, I'm leading a small study in Rhode Island to help implement HPV self-collection in a community clinic that serves uninsured Rhode Islanders, largely immigrant women, about 80% Spanish speaking, a very quite high risk of cervical cancer, largely unscreened population and transient population. And we helped co-design with the clinic staff and leaders this patient education and clinical workflows to implement HPV self-collection. And then we pilot it, and we just wrapped that up. And we surveyed patients pre and post about their experiences and their questions, concerns, and experiences. And then also got input from staff and leaders about the implementation and how they see this moving forward in terms of scaling it up in clinical practice. So everyone was very happy. The staff were happy to hear that patients liked it. They weren't sure in their population how it was going to be received or whether there were going to be some differences by ages and experience, but it was highly acceptable to women. And so they're thinking about, and they had been interested in it as an access problem because they had a shortage of capacity for GYN exams. And so they were trying to solve a problem with this, easier access to screening, but we're happy to find that it was perhaps even a preferred option for their patients. So, I like the way that research and clinical care can come together in terms of informing how our approaches. And we'll share those. We've been sharing those lessons in kind of local health systems, and we'll try to spread that regionally through state cancer coalitions and elsewhere. And then a sort of side project that I've been doing is working on an online web-based tool that's an HPV self-collection shared decision-making tool, so that it helps people kind of self-screen for whether they're eligible in terms of age, making sure they're not immunocompromised or don't have any active bleeding or a recent history of abnormal screening, etc. And then if they do that screening and discover that they're eligible, there's a question and answer about what self-collection is, and also more broadly about what HPV and cervical cancer screening, those kinds of factors. And so we're just wrapping those interviews up. We interviewed providers, staff, and patients, and most find it easy to use. They're very curious about self-collection and found it helpful to understand a little bit the difference between self-collection and clinician collection. And felt like it might be useful if it were sent when they're invited for screening, so they have a little bit of preparation before they see their healthcare provider. So that will be interesting and the next step will be to test that to see if it does impact both cancer health literacy, cancer screening health literacy, and also uptake of screening. So that'll be the next step there. So to wrap up, HPV and cervical cancer has been a very exciting field to be a part of in the last 20 years because it's it's rapidly evolving, and it's pretty exciting to be in a field where, you know, we could eliminate this health problem. You know, we have the tools, we have the knowledge, but we have to figure out how to get it into policy and practice to impact outcomes. I remember years ago being with folks at a conference who were more in the HIV world, and they sort of looked at us and went, "What are you doing? You have a vaccine, right? Like, this can really work." But this is where all the work I've done in implementation science, I understand there's a lot that gets in the way, even when we know what works. So that's, you know, I do think that we can think about how do we promote gender responsive care to sort of push the needle forward in terms of even further understanding what some of those barriers are, and how can we leverage some of the successes from cervical cancer, screening and early detection for breast and colorectal cancer, and vice versa, right? What if we learned about the uptake of home-based testing for colorectal cancer screening, and how does that inform us in terms of cervical screening approaches? And how can we better prepare nurses and health professionals to lead and optimize care for women in all their diversities? So I thank you for listening. My email is there, and LinkedIn. Please reach out if you'd like to continue the conversations. I want to thank Professor Midwifery for the invitation to this lovely city and to Trinity College Dublin. And thank you who are here in the room and everybody online whom I can't see, but I hope you've heard me. So it's a pleasure to be here today.
Yes.
That was fantastic, and thank you, Erica. I wonder if anybody online or in the room have any questions.
I'm going to stop sharing.
Yes, perhaps. And keep an eye in case any chats are on here. I suppose one of the questions I do have is just, I suppose, thinking about the US as a largely privatized health system, how have insurance companies influenced the uptake of the screening in any form for cervical cancer, whether it's pap smear or HPV based?
Thank you for that question, because it is part of the confusion. So it is a bit of the safety net that people will get notifications from their insurance that they're due for screening, which has been an effort to increase uptake. And I'm actually part of a state cancer coalition advocacy group where there are some members of insurance companies who are involved in this. So I think those are good efforts, but it has also contributed to confusion as guidelines evolve, because people are getting mixed messages about you're overdue, but someone knows they're hearing from their healthcare provider that they're not overdue. And conversely, they may be incentivized if they get sort of, sometimes you get sort of wellness points or money back on your insurance if you go do your preventive care, to incentivize preventive care, but you may be compelled to do something sooner than you actually need to. So I would say it has potential, and that could be a source of information for the general public. But it is, yeah, it does make it, you're right, it's not health system dependent. There's this other dynamic of the privatized insurances where the messages are coming directly to consumers that way.
Yeah, so I have found that the HPV distillation tool, I'm just interested in what kind of questions you're asking in the choice for self-sampling that someone might end up being ineligible or not suitable to them. In what case would that be?
Yeah, there aren't that many factors. So the age, so if you're under 25, HPV self-collection is not HPV primary screening is not recommended. That's because in the younger age group, HPV is so prevalent, we don't, but it will likely go away. So we don't generally, so that's just an age eligibility. The other, if you have, the only sort of symptom-based thing that we really want to have someone have an exam is if they have abnormal bleeding, because that can be a warning sign for cervical cancer. And so it's not just, do you have your period today? That's still not recommended because it might interfere with the test, but more so, do you have any abnormal bleeding? Right now, they're saying that if you're pregnant, you shouldn't do it. That will probably go away, but that's one of those things. It may be just to make sure that people are getting care, but yeah, it's not an absolute reason. And then the other, there are two other categories where it's not recommended because they want someone to be seen. someone who has HIV or is taking medications, that immunosuppressive medications, they should be screened more frequently, and it's recommended that the cervix be visualized and examined. And then the other is if someone has a history of abnormal screenings in the last 5 to 7 years, it's generally recommended that they have clinician collected for the same reason. Although if someone just had a test last year and maybe it was just a positive HPV test, it is acceptable to do another test, and maybe it would be negative. But so those are the only things. It's not a complex set of questions that would make someone ineligible or make them have the impression that they would be eligible. And in the US context, of course, they're needing to access the self-collection via a healthcare provider anyway, so there's an opportunity to understand that. If it were direct sort of self-screening to whether you would order a test on your own, it might be a different consequence. But in this case, they're going to have a conversation anyway.
Yeah. So it's for the individual or the healthcare provider?
Well, that's a bit of what we're talking. We've talked to folks who see patients in clinics and said, would you sit with a patient, or is it someone who's doing outreach on the telephone that might sort of use it as an eligibility screening or a shared education tool? So people are thinking about how they might use it. Most have thought they might use it as pushing through a patient portal, an electronic portal through the electronic health record, to sort of say, you're due for your screening, click on this link if you're interested in knowing more about, to understand your screening options. So it will likely be self-administered, but it could be used in conversation with patients in the healthcare provider office. Yeah. Go ahead.
My name is Jasmine, and I'm a postgraduate student in the Global Health program here at Trinity. One of the things I'd love to hear more about, if you had more resources on some of the emerging technologies, thinking about diagnostic care for women in this kind of landscape, and the accuracy of those tools. And then this may be a bit more of a loaded question too, so I'm happy to ask that individually. But just trying to get a sense of the global health landscape right now, given shifting priorities, lack of funding, and all of these things. Do you have a sense of the narrative that's kind of going on the ground of like what is needing to be prioritized in this kind of space as we think about screening, detection, and all of these things?
Yeah, thank you. Those are great questions. So the biggest technology that's being worked on in the global space right now through agencies like IARC, which is the cancer research arm of the World Health Organization, and other through the National Cancer Institute in the US, are AI-directed visual assessment for treatment. So if we go to HPV-based testing, say in Kenya then one of the things where you don't have in the US or in other settings, your triage test, your next follow-up test would be cytology. But in places where cytology doesn't exist or it's of not good quality, then the next test, the triage test, is different. And so the visual assessment, so all the trainings I did in terms of visual assessment of the cervix, that's now being used as someone has a positive HPV result, then you have to assess them for treatment. And it depends on the country, what that protocol is. Mm-hmm. Some would just go ahead and give treatment for someone who is HPV positive, but it's a little complicated, for instance, in HIV endemic areas where the positivity may be high but it's not, it might be over treatment. So they're testing these algorithms, and there are some large scale studies going on in India, and in Brazil, and in places in Zambia and South Africa, where they're really trying to train these algorithms, because I haven't done much in AI, but I have understood it's very fickle in terms of population, and we really have to test it in different populations to understand how it performs. So I think that's promising on the horizon, and so I think there is a commitment to historically cervical cancer prevention and cancer in general has been lower priority in places where for many years, right, the pressing issues in terms of global health were infectious disease and maternal child health, maternal mortality, that kind of thing. And there is now much more attention to non-communicable diseases, including cancer, as you know, in the field of global health because of demographic shifts and because of policy shifts. So yes, I think the funding, abrupt funding changes has impacted this. I mean, we know the rates of HIV are going to go up, so we may be more in, we're already seeing that, so we may be more in crisis there. But I think there is, HPV-based testing, if we can get the cost down and the sort of refine the tests that can be done, and more, I think I was having a conversation here about the more it can be point of care, right? So you can offer screening and treatment in that same day. So the woman who's walked, 10 kilometers to come to the health center doesn't have to then come back. So I think that's that's where cervical cancer prevention fits in. But more and more, of course, it's going to be dependent on what individual countries can set in terms of policy. But that, that's where policies like the, countries that have signed on to a cervical cancer elimination plan have invested resources that way. So to be determined, but in terms of technology evolution and, a great desire to optimize and lower the cost of HPV testing is there. So it's hopeful.
It's exciting.
Go ahead.
Yeah, I was not dissimilar question, but with the eliminating cervical cancer programs that are in Ireland, Australia, the UK now, 2040 is what Ireland is aiming for. And we know vaccination in the likes of Hungary and Bulgaria is like 3% to 7%. So is there going to, do you feel like there's going to be a growing inequity, and as screening programs change to contend with the fact that cervical cancer is eliminated by 2040 in some of these countries, is there going to be an inequity then across Eastern Europe? And
yeah. Well, you saw that if we think about the European region. Yes, I think we will see. We already see inequities in terms of subpopulations within high-income countries. But I think we will see those programs with highly organized screening programs, strong, screening coverage, and high HPV vaccination rates. The modeling suggests it may be, especially the HPV vaccination impact. Is that population's age? There's going to be a growing disparity between the two. So who knows where, even within a region, resources might be invested. In terms of partnering with other countries, mostly to move towards more organized and centralized data systems to understand coverage for vaccination and screening. And then treatment, at least in the US context, is the hardest to track and measure. And that's a really important pillar too, because we may see people who do screening, but they're not doing the follow-up, get the treatment.
Thank you. So I'd like to, we're just at time. So
Yes.
I can see the webinar, just that we do close on time, but we'll be here. And Erica, if people would have more questions that would like to approach Erica one-on-one, absolutely. But I really want to say thank you so much to Erica for coming all this way. For sharing such a fantastic talk. It has been absolutely riveting, and I think it's just been really helpful to see how other perspectives can help to influence the screening services that we have here, what we know from research that has been ongoing within the Irish context. I think there's a lot we can learn from the work that you've been doing in global contexts. So thank you so much for sharing your experience, and thank you to everybody in the room and online for joining us. And if any questions, you have contact details and can follow up.
Thank you.